Welcome back to What the Study Says. Today, we're diving into a high-stakes clinical showdown. It's a situation where the right choice can save a brain, and the wrong one, well, it can have some devastating consequences.
So picture this. You're on the front lines. A patient starts seizing, and you figure it out. It's severe hyponatremia. Their brain is under intense pressure, the clock is absolutely ticking, and your next move is critical. What do you do?
All right, first things first. To win this fight, you have got to understand the enemy you're up against. So when sodium levels in the blood just plummet, basic osmosis goes completely haywire. Water floods from the bloodstream right into the brain cells to try and balance things out. And the result? The brain literally becomes waterlogged. And since the skull can't exactly expand, the pressure inside can become catastrophic and fast. Okay, so how in the world do we fight back when a brain is swelling up against the inside of the skull?
Well, we have a pretty powerful tool in our arsenal, 3% hypertonic saline. You can think of it as super concentrated salt water. When we infuse it, it acts like this powerful magnet, just pulling that excess water right out of the brain cells and back into the bloodstream, and that releases the pressure. But you know, the real debate isn't what we use, it's how we use it.
And this brings us to a really long-standing debate in emergency and critical care medicine, a true clinical showdown between two totally competing strategies.
In one corner, you've got the challenger, the rapid intermittent bolus, or RIB. This is kind of like giving a quick, powerful shot of espresso to the brain. And in the other corner, you have the old guard, slow continuous infusion, or SCI. This is that more traditional, cautious approach, like a slow coffee drip. For years, the conventional wisdom was that going fast was just too dangerous. The big fear was overcorrecting the sodium and causing something called osmotic demyelination, which is a really devastating neurological injury. But is that fear actually supported by the evidence? Let's see what the research has to say.
And this is where the SALSA trial comes in. It's a landmark 2021 study published in JAMA Internal Medicine, and it gave us the head-to-head comparison that clinicians desperately needed.
So first, the trial tackled the biggest fear, overcorrection. And what did they find? Well, the rapid bolus group had an overcorrection rate of about 17% versus 24% for the slow infusion group. Statistically speaking, there was no significant difference. This basically means the main argument for that slow, safer approach, it just didn't hold up. But while the risk of overshooting turned out to be a wash between the two methods, that wasn't even the most surprising finding. The real difference was something else entirely. Okay, so the study looked at how often doctors had to step in to stop the sodium from rising too fast, basically how often they had to slam on the brakes. And this is shocking. The safer, slow infusion group needed this intervention 57% of the time, compared to only 41% in the rapid bolus group. The method that was supposed to be safer was actually harder to control. Wild, right? So with this data, the trial's authors made their conclusion crystal clear. They said that the rapid intermittent bolus, quote, could be suggested as the preferred treatment. The evidence was really pointing in a whole new direction. So what does this all mean for you, on the ground, in the middle of a crazy shift? Let's turn this evidence into a practical, modern playbook. All right, so here's the modern protocol, pretty much adapted from major European guidelines. It's simple and direct. For severe symptoms, like a seizure, you give a 150 milliliter bolus of 3% saline over 20 minutes. Then you check the sodium. If symptoms are still there, you can repeat the bolus. The goal isn't to get them back to normal right away. It's a targeted 4 to 6 millimoles per liter increase just to stop the crisis. Now, of course, safety is absolutely key here. It isn't just about the administration method. It's about being super vigilant with your monitoring. You're going to check the sodium right after the bolus, then again at 1, 6, and 12 hours, and then frequently after that. You stop the aggressive treatment as soon as the patient's symptoms improve, or you've hit a total increase of about 10.
So let's look at the final verdict. Why did the challenger, the bolus, win this showdown so decisively?
Let's just break it down. The bolus method is faster and way more efficient in that critical first hour when you're trying to stop a seizure. Paradoxically, it's actually easier to control and leads to less overshooting. It's not riskier, and it gives us a simple, clear, and repeatable protocol. And in a crisis, simple is safe. And this leaves us with a final thought, and it's a big one. The evidence we've talked about isn't brand new. The SALSA trial was 2021. So why, in so many places, is slow infusion still the default? It really highlights a critical gap in medicine.
the time it takes for high-quality evidence to actually change day-to-day practice at the bedside.
And that's all for today's explainer. You know, closing that gap between evidence and practice is really what we're all about here. If you found this helpful, please subscribe and share what the study says. We'll see you next time.